So I'm going to be speaking on guidelines for the perioperative use of opioids in the UK. As you've just heard, I'm a lead author for a number of international guidelines and national guidelines on perioperative use of opioids, including the college ones, and the one on the far left, which I did with Roger and Dilip, and was kindly published in Anaesthesia. So that's another plug for Anaesthesia. So what are the aims of the talk is I want to discuss why guidelines are needed. Then we'll look at some of the causes of the prescribed opioid crisis. And we'll look at drivers and remedial guidance for PPOU, persistent post-operative opioid use, opioid-induced ventilator impairment, OIVI, opioid diversion, and drug driving. And then we'll look at what I think are my top 10 recommendations. So why are guidelines needed? Opioids do have a role to play in surgery. There's huge benefits to them. They provide humanitarian pain relief, and as we've heard from Matt, they do promote recovery and restoration of function. But on the other side, there are risks, and there's the opioid-related adverse drug events. There's PPOU, persistent post-operative opioid use, OIVI, opioid-induced ventilatory impairment, opioid diversion, and drug driving. And I think we're probably fully aware that as well as there being a COVID crisis epidemic, there's also an opioid epidemic. These are the numbers from America, and essentially over the last 20 years, 50,000 people a year on average have died from opioids. 50,000. And this has caused huge amount of social and community damage. And if we look at the American data a little bit closer, we can see actually that there's 3 waves of opioid deaths. 20 odd years ago, opioid deaths in the States were quite rare. Likewise in the UK, I haven't got the data for the UK, but we are following this curve, but fortunately not as badly. And what you can see there is that there's 3 waves. The first wave was the prescription opioid, prescribed opioid deaths, which went from 1999 to 2010. And then something happened in 2010, and I can tell you what later on. And there was a rise in heroin overdose deaths, and that started in 2010. And then more recently, there's been the rise in synthetic opioid deaths, synthetic opioids such as tramadol and fentanyl. Having agreed that there has been a prescribed opioid epidemic, let's look at some of the drivers. So I think we're all familiar with the WHO pain ladder that was developed for cancer pain. The only problem is, in the late 90s, a certain company called Purdue Pharma hijacked it and suggested that opioids could be used for chronic pain management. Before that, opioids weren't being used for chronic pain. And so that's what Purdue did. They also promoted pain is the 5th vital sign. They paid the American Pain Association, the American Pain Society, to promote pain is the 5th vital sign. And again, it's not surprising that we have stopped using pain is the 5th vital sign because of the way that it's driven the prescribed opioid crisis. Also in America, Purdue corrupted the whole equivalent of CQC, the Joint Commission, so that hospitals were being paid by patient-reported outcomes and their pain scores. But if patients reported that the hospital did not do all in its power to alleviate their pain, the hospital wasn't paid as much. And so you can see that was a driver for doctors prescribing opioids. Doctors were also misled by the sales rep that Oxycontin was safe. Purdue are the manufacturers of Oxycontin. Doctors were misled that addiction to Oxycontin was very rare. And doctors were also misled that Oxycontin lasted 12 hours. This was all done by Purdue and the Sackler family, who are one of the wealthiest families in America. And I don't know how many of you have seen or read these books, The Empire of Pain, Dopesick, which was published about 5 years ago and has been made into an excellent program series on Disney Plus. All 2 books I would highly recommend, and I would also recommend reading the Dopesick, watching Dopesick on television. Let's also look at Oxycontin. It's a modified release opioid that allegedly has a 12-hour profile, and that's what the Purdue want us to believe. Actually, in the vast majority of people, it's got a profile that lasts shorter than 8 hours. It's advertised as having no peaks or troughs, and the active opioid is oxycodone. Now, the interesting thing about oxycodone, it is the most likable opioid. It's not just the pharmacokinetics that predispose to dependence with Oxycontin. It's the fact that it's a very nice drug. It's devoid of side effects, and you get a nice feeling. I just want to share this bit of advertising from Purdue Pharma, and as you can see, there's no peaks or troughs. However, for the very vigilant amongst you, you will see that actually it's a log scale, and therefore it's not surprising that there's no peaks or troughs to cause euphoria or dysphoria. And this is just one of the tricks that the company used on doctors to demonstrate that it was safe. As I say, we're told that it's got a 12-hour duration of action. Think about that, 12 hours on, off. How many other drugs do you know that have a predictable 12-hour action? And here are the theoretical advantages of MR opioids. You get better pain control, you get fewer side effects, it's easier to administer, and you get less less addiction because you've got the fewer peaks and troughs. But actually, as you can see, with the way that I've annotated this diagram, you've got 8 hours of action in the majority of people, and so you do get a massive trough. And you've got a whole window where the patient has got no pain control, and this is where you get dose escalation. And you can see why Oxycontin is the most addictive opioid going, because it's purely because of the pharmacokinetics and the pharmacodynamics. Actually, think about it. A company that can pay 8.3 billion in fines must have earned a lot, and it's all through deception. And the tactics that the family and the company use are despicable. And there's just another advert. And as you can see, these are all dangerous lies. The promotion of the WHO pain ladder for acute and chronic pain is a lie. The promotion of opioids for chronic non-cancer pain is a lie. The promotion of pain as the 5th vital sign is a lie. The payment by patient-reported outcomes just escalated their use. Oxycontin is not safe. Addiction to Oxycontin is common, and it doesn't last 12 hours. And it's just as much as a lie as saying that no rules were broken and the guidance was followed at all times. These are all dangerous lies. Let's look at evidence for Oxycontin as part of fast-track surgery. There is no real evidence. The evidence that Purdue did and brought out was comparing Oxycontin either to controls or to PCAs and epidurals. And if you're looking at a procedure, an anaesthetic that includes a PCA or an epidural where you tether the patient to the bed space, it's not surprising that an oral preparation does facilitate earlier mobilization and earlier discharge. So let's look at Oxycontin in unbiased studies. This is a study done in cardiac patients where they were comparing immediate release oxycodone with Oxycontin. And as you can see, actually, the pain relief provided by immediate release Percocet was superior to Oxycontin. And actually, the patients on Oxycontin got more side effects. And they required significantly less rescue medication. So that paper was done in 2007. This is a paper that was done recently in Australia. And you can see when you compare immediate release Oxycontin versus slow release Oxycontin, patients had more pain at rest and during movement with the modified release Oxycontin. It does not lead to superior pain relief. And you can see also that the opioid requirements were higher in the slow release opioid group. And actually, the UK is not immune to this opioid epidemic crisis. 5% of the population misuse prescribed opioids, and it is worse in areas of deprivation. So hopefully we've looked at why guidelines needed and the causes of the prescribed opioid crisis. In the next 10 minutes, I want to look at the drivers and the remedial guidance for PPOU and OIBI. So persistent post-operative opioid use is now the most common complication of surgery in the US. And it's got an incidence of anywhere between 0.1 to 26% in opioid naive and 35 to 77% if they were previously opioid exposed. We mustn't forget that one of the causes of the prescribed opioid epidemic is surgery as well. When I was a houseman 30 years ago, I didn't do any TTOs for opioids. The patients had been deprescribed by the time they'd left the hospital. But mind you, hospital stay was 2 weeks for the majority of major procedures. And this is just a paper that was published a year or two back that shows that surgery in the UK is a risk factor for subsequent opioid dependence. And this is a paper that Dilip led on and looked at prescribing habits of doctors after surgery within the East Midlands. And as you can see, after major surgery, almost 10% of patients were being discharged with modified release opioids. And after intermediate surgery, hernias and the like, it was 5% of patients. And surprisingly, some of us were even prescribing the patients PRN, modified release opioids. Let's look at some of the drivers and remedial guidance for PPOU. The major drivers are modified release, repeat prescriptions, and the long duration of the initial prescription. For this bit, I will refer to the paper that we did in anesthesia. So it's hardly surprising that most of our guidance is going to be against the use of modified release opioids. It's about reducing the duration of the initial prescription. And as you can see from the American data, it's at 5 days that there is the inflection point of when the lightness of dependency really starts. And there's always the risk. And lastly, there's the issue of repeat prescriptions. This is just looking at now the number of international studies, societies that suggest that modified release opioids have no place in the management of acute pain because of the risk of dependence. So our guidance is long-acting opioids should not be routinely used for acute post-operative pain, whether it be Oxycontin or fentanyl patches. As I said, 5 days in the inflection point, so they need a limited duration. And please remember the MHRA guidance from a year ago that stated that transdermal patches have no place for non-cancer pain in opioid-naive patients. And under our GMC guidance, it's our duty to comply with the MHRA and official guidance, either whether it be from the AAGBI or the Royal College of Anaesthetists. And both societies and colleges state that we should not be using modified release opioids. We need to be giving deprescribing advice, telling patients how to stop their medication. And I think it's about 8 years ago now, 7, 8 years ago, we wrote that editorial in Anesthesia that suggested that we as anaesthetists have a duty to promote deprescribing, and the British Pain Society have recently released this guideline, patient information leaflet, to tell patients how to wean off their opioids. I now want to move on to opioid-induced ventilatory impairment, which is a triad of depression of the respiratory center. So it's not just respiratory depression, but there's also depression of supraglottic airway muscle tone. And that's why patients with obstructive sleep apnea are more at risk of OIVI. And there's also the depression of consciousness. And this slide just highlights the fact that actually it's depression of the supraglottic airway muscle tone as well. And again, it's depression of the orexin arousal center. So what are the repercussions of opioid-induced ventilatory impairment? Well, the big thing, it's death and hypoxic brain damage. And all those 50,000 people a year that are dying in the States, they're dying from OIVI. So what are the risk factors for OIVI? Not modifying the opioid dose according to the age, initiation of long-acting opioids, it's our friend again, co-administration of sedatives, reliance on unidimensional pain scores, and inadequate monitoring and track and trigger. So there is increasing evidence that when we give opioids to elderly folk in the same dose that we give it to younger folk, they get OIVI. So actually, we need to reduce the dose of opioids that we give to the elderly folk in a similar way that the amount of alcohol that you require now to get yourself drunk is considerably less to what you required as an 18-year-old student. The same thing happens now with opioids. The same, if you give an equipotent dose of opioids to the elderly, you're going to cause harm. Don't give long-acting opioids. Give immediate release, age-adjusted doses of opioids. Do not give co-sedatives, especially the gabapentinoids. And there's evidence that when we titrate using the pain as the fifth vital sign, opioids to artificially reduce the pain as fifth vital numerical pain score, we cause sedation and harm. Therefore, we should be increasingly reliant on the functional pain scores. But there is a place still for the numerical pain score, and it's mainly to monitor the pain trajectory. This is the pain as the fifth vital sign, and below is the article that I co-wrote that really looks at the dangers of our dependence on the pain as the fifth vital sign and the numerical pain scores. And that we're now suggesting that a function should be used. This is the Australian Functional Pain Score. and it's 3 categories, A, B, and C, and we should be aiming for only mild or no limitation of function and titrating opioids to promote that. The current new score does not detect impending OIVI, so that there are alternative various sedation scores, and on the far right is the one that we've adopted and is promoted by the Australian and New Zealand College of Anaesthesia and its Faculty of Pain Medicine, and it's a 3 score. Moving on, we mustn't forget the harms that are caused by leaving opioids around, which then allows family and friends to get hold of our prescribed opioids, our illicitly prescribed opioids, which then become illicitly used for opioid diversion. So therefore, it is essential that patients should be advised on self-storage and advised on safe disposal of their unused opioids. And they should be directed to avoid opioid diversion to other individuals. We mustn't also forget that driving under the influence of prescribed drugs causes accidents, and so there is advice on both in the BNF, and it's a legal requirement that patients do not drug drive, because that is now a criminal offence under 2015 legislation. So in summary, I hope we've gone through these 5 or 6 areas. And this is a slide that comes out of a paper I did with Dilip, and is all about opioid stewardship and making the perioperative use of opioids safer. And as you can see, actually, it starts preoperatively with the psychological optimization and management of patient expectations. They're having surgery, there will be discomfort, but we will do our best to manage it and promote them going home in a safe manner. Assessing function rather than being reliant on unidimensional pain scores, must be promoting multimodal analgesia. I'm getting like a gramophone. We need to avoid long-acting opioids and also compound opioids because they hinder deprescribing. You've guessed it, we need to limit the number of number of tablets and the duration of discharge opioids, and we need to give patients deprescribing advice. And we also need to be educated to promote safer use of opioids. You probably worked out what my top 10 recommendations are. Avoid modified release preparations, avoid repeat prescriptions of opioids, limit the duration, and we need to treat opioids as a course of treatment, not like a lifelong thing. Treat it like antibiotics. Same thing as antibiotics. There's antibiotic stewardship. There needs to be opioid stewardship. There needs to be a patient partnership with education. We need to be promoting deprescribing. And as news does not identify OIVI, we do need sedation scoring. We need to administer opioids to promote function. We need to avoid co-sedatives and promote safe disposal, and have patient information leaflets to reiterate. I'm now going to call it a day, and I'm going to say thank you very much for your attention.